on stage Dr. Shalini Nalvad Madam. She is the chairperson at the International Critical Care Air Transfer Team Foundation, co-founder and a director of ICATT Air Ambulance Services. She has done fellowship in aeromedical science. She is a vice chairman at head Southern Indian Regional Officers Federation of Industries of India. It's a very interesting topic. Over to you, madam.
Before Madam starts,
it's an honor to address you all united through shared passion for anesthesia and critical care, and also the emergency medicine, which Madam just spoke about, the perimortem cesarean section. I thank ISA, Mysore chapter, Dr. Manjula and the team for having me as a speaker today. I'm speaking on behalf of ICAT Air Ambulance, International Critical Care Air Transfer Team, we call it. I'm an anesthetist like you, and I would like to address this for all the future anesthetic consultants, the junior anesthetists who are sitting in this hall, to consider this as one of the emerging specialties which is extremely interesting and also a life-saving thing. So this is my team of aeromedical doctors. We call them aeromedical commandos. The reason we call them aeromedical commandos is they can fly in a helicopter or in a fixed-wing aircraft and do the procedures in a pre-hospital environment or in a inter-hospital or on board. I'd just like to start about a story. I think Dr. Shivkumar might know, he's from Shimoga. This is a young chap, Dr. Vinay. He's a celebrity wildlife doctor. He was trying to capture an elephant which had killed 2 college students a week ago. He had positioned his gun, trying to tranquilize the elephant, and this elephant charged him right head on. Even before he took position to shoot this elephant with the sedatives, it hauled him to the ground and just stamped him on his chest. You can imagine what exactly happens if an elephant has his feet on anyone's chest. Of course, he had pneumothorax, hemothoracis, scapular fracture, flail chest, everything you can imagine. He was taken to Nanjappa Hospital in Shimoga, and he was initially resuscitated, and they did an extremely good job. We were called because they had to move him to Manipal Hospital. He was an FiO2 of 0.6, saturating at around 96 to 97%, but we exactly knew if we move him, what's going to happen. He might rebleed, he might get sick. We didn't know how we were going to transfer this patient without, how much more can you stabilize? We decided to put him on VV ECMO. This is India's first trauma VV ECMO. It just happened like 2 months ago. We put him on VV ECMO. We normally airlift them. Unfortunately, Shimoga Airport, which was although inaugurated by the Prime Minister a week ago, it wasn't operational with the ATC and ADC and other things. So we decided to bring him by road. Road journey from Bangalore to Shimoga is nearly 6 hours. In 6 hours, if you have to bring this extremely frail, a kind of a national hero, and something goes wrong, where the government and everybody involved, more than that, he was a young father. We decided to get a green corridor. Fortunately, between 5 district SPs with the Joint Commissioner of Traffic heading from Bangalore, we completed this transfer from door of Shimoga Hospital to Manipal Hospital within 238 minutes. That's less than 4 hours. It was like he was kind of, we had the escort with green corridor through and through. Next thing, you can see him there with his family after he's recovered 52 days after the injury. I would like to quote another instance. He's a minister serving in the previous BJP government. He was traveling by road, met with an accident near Gulbarga, had a fractured humerus. It was fixed in a hospital there. And very next day, post-op day 1, he had a cardiac arrest. He He had a cardiac arrest on the ward, so they just rushed him to the accident emergency. They intubated him because the resus room was there. And he kept having continuous cardiac arrest. Although his echo and ECG pre-op were normal, of course, you can't detect all the things on the normal ECG, and echo will not pick it up. We were called, I got a call at 6 o'clock in the evening. 6:30, team was out of the base. Unfortunately, Gulbarga airport closes at 5:30. We couldn't take an air ambulance go. So the team went to airport, Bangalore International Airport, which luckily we are 15 minutes away from the airport. We boarded the flight to Hyderabad. We drew down to Gulbarga. This guy started having multi-organ dysfunction, and we put him on VA ECMO at 2 o'clock in the morning. Next day, we flew him to Manipal Hospital. He hoisted the flag on Jan 26th, back in his office, fully recovered. These are the stories which kind of, or you can say you are capable of, is that we are empowered with. When we were dealing with COVID patients, we are flying patients, nearly 5 ECMO patients every day, because there are only 5 planes in India which can take a patient. We are not proud of those 250 ECMOs we initiated and transferred, and most of them recovered. We are very, very embarrassed about the fact the patients we left behind, and even today it haunts us like a nightmare of the people when we had to triage between a 28-year-old pregnant girl and a non-pregnant girl. Coming back to air ambulance again, the air ambulances are used in organ airlifts as well. We do 95% of the organ airlifts. I trained in anesthesia critical care aeromedical from the UK. I came back to India and we established this service in 2017. Now part of 4 ambulance service, 4 different companies. The reason I'm bringing this is I want to invigorate that entrepreneurial mind in anesthetists who traditionally think their job is just in the theater between the blood-brain barrier. So I want you guys to shatter that and come out, not only be the best anesthetist, not just being the best critical care doctor. All of us sitting in that anesthetic room, our brain has much more lateral thinking than anyone else. That lateral thinking, I want you to bring out your entrepreneurial skill and make a difference to the society and to the country. So ICAT Air Ambulance Services is a private limited company. ICAT Foundation is a philanthropic or a NGO wing which I chair. We have done 43 crore of work until today in just 2 years of time. And ICAT modules, we didn't just limit to India. We expanded in overseas. We started doing air ambulance transfers in Maldives as well, using seaplanes and speedboats because they have 9 islands there. And the education, what we do, is called FAM education, that is Fellowship in Aeromedical Sciences, where we train doctors to become aeromedical commandos. We have been covered by BBC as well. We did one of the world's longest aeromedical retrieval of a multi-organ dysfunction lady from Portland, Oregon to Chennai. So this was covered by BBC, and normally BBC has to pick up a news. It has to be really good. During COVID lockdown, when the entire world was shut, all the countries had shut their airports, we brought a Bank of Baroda employee from Johannesburg to India. Of course, it took us 30 hours because we had to night halt in Mauritius without getting quarantined in any country and refueling by getting this airport opened. We started this service by commercial airlines as well. Because everyone can't afford air ambulance, we started putting stretchers in only for the international transfers, where we take over 9 seats, enclosed area, and bring these patients on commercial airlines, but using the same equipment and the same team without compromising the quality. As I said, we do 95% of the organ airlifts. The organ airlifts are extremely critical in terms of the cold ischemic time we have. We have done from theater door to theater door within 80 minutes from Chennai to Hyderabad to Chennai. Every day we create a history in that. We used 4 planes for 1 organ. We have done using 2 planes, 5 organs. We are almost like, every day it is kind of writing a new history. We were the first people in the world to put a patient in an isolation pod. Isolation pod was used during COVID because no aviation, even today you can't walk into airport if you have higher temperature. Until recently they were doing thermal scanning. At that point, we brought an isolation pod from Germany, and we put the patient inside the isolation pod and convinced this entire aviation industry patients could be safely airlifted without the pilots or the airport ground handlers or anybody else getting infected. So this is Mahato, Education Minister, who's a patient. He was the first patient in the world to go inside an isolation pod on ECMO. This is Jharkhand Chief Minister Shibu Soren, if you see. Again, 225 ECMOs in the world is a history again. No one single organization has so many initiations within 8 months of time. So we do ECMO initiation transfers, ventilator transfers, telemedicine. We operated during Kerala disaster. We put our helicopter there, airlifted patients free of cost from all the relief camps. This is our Kerala pictures, and I know I have just 5 more minutes left. This is the fleet we use. We used fixed-wing air ambulances, that is planes, which is 7-seater planes up to 15-seater. We normally use the jets for longer distances like international transfers because they fly faster, and we use them when we do organ airlifts because we have like from the long places like, if you're bringing organ from Delhi or Jaipur or Chandigarh, then we use twin-engine jets. But of course, it's more expensive. We use turboprops. These are the turboprops, which has propellers. We use them in domestic transfers within India, and these are the helicopters which are used in emergencies. We're designing the Cirrus Mark II aircraft with NAL to make world's first flying ICU and operation theater, which will have a very long endurance, which will have a central operating table or like procedural table, because normally in air ambulance now the table stretches out to the wall and we do not have a 360-degree access. So this will be an aircraft which can fly anywhere in India, which will be kind of because it's a Make in India project coming at a very, very nominal rate. So why is this air ambulance? It looks very glamorous, but it is the most difficult thing to do. The reason being, we are integrating very two sensitive fields, aviation and critical care medicine. The challenges are with the weather, there is challenges with the costing, there is a support system, connectivity, and there is complication because families are involved, there are pilot timings, pilot's attitude, they're worse than lorry drivers, believe me. Loading, unloading of the patients during COVID, none of the ground handlers would come to load the patient up to the aircraft because they used to think like, okay, we'll get infected, how to crack them. And of course, we get involved with a lot of VIPs as well. So there's a VIP syndrome, like when we are dealing with the patients. There are problems with the altitude, there's problem with physiology, there were problems with the oxygen shortage during that time, and every airport is different, every receiving hospital is different, every referral hospital is different, and you're doing what you do in your comfort zone, totally in a world full of variables. How did we master this? Of course, standard operating procedures. There was no SOP how to do an organ airlift when we came back from India. 90% of the organ which were airliftable or which were transplantable used to go into waste. Now, I'm extremely proud to say and touch it, and whatever the organ that has come through our door, we have been 100% successful. Sheer hard work, every single minute you need to put your time in, and they say, sometimes you end up working 22 hours, 23 hours, if there are 24 hours, and especially when it gets morning, we have a patient transfer, evening we have organ, and there's another international transfer going on, Americans trying to speak to us, but around, like when they wake up, it will be 2 o'clock in the morning for us, and they start coming on the conference calls. So with all the time difference and all the work we do, and most of the organ retrievals happen middle of the night, then we brought in checklist. For every single thing we have checklist. We have I just give an example. There is a patient, 32-year-old lady in Gandhidham. Gandhidham is in Gujarat. It's a coastal city. Doesn't have much good connectivity in terms of commercial. And during COVID, most of the airports were shut. So this family requested us to come and initiate an ECMO. Of course, the perfusionist who was going was not very, he's kind of not very experienced. So they asked a charter plane to bring the team and equipments. When the team took the charter plane to Gandhidham, this perfusionist forgot to take his ECMO circuit, and he just walked into the hospital. The team of cardiothoracic surgeons and the cardiologist, cardiac anesthetist sat down and counseled the family about ECMO, giving all the indications, contraindication, complications. Family said, yes, let's go ahead. They realized they don't have ECMO circuit. You can imagine people asking, bringing a charter plane to bring, there were 4 brothers and 1 sister, extremely powerful family in terms of both muscle power, money power, and everything. These guys thought they'll be killed any minute. So that was a time there was severe shortage of ECMO circuits. We were consuming 11 circuits in a week and absolutely no circuits anywhere in the country. We had to, somehow we found one in Ahmedabad, 2 taxis had to be taken, and then we ultimately got, before anything could happen, although she was kind of, she didn't destabilize anymore. ECMO went in successfully. That night, oxygen dropped, pressure dropped in the hospital. Again, get an oxygen cylinder, put the patient on the oxygen cylinder, stabilizer. Next day morning, we sent the air ambulance out to bring this patient back. When the air ambulance went, they went out of the radar. They went out of the radar because it's a coastal region, there was wind, and the pilot took a diversion. We lost the plane. Nothing happened to the plane or the crew, but they landed back again. Now you can imagine, like, every second there is a challenge or something that can go wrong. And disease, again, as I said, it's a world of variable. I think I know my time's up in this, and if anybody want to connect up, you can, or of course, always, especially the junior doctors and junior anesthetists, always welcome to talk to me. I'll just run through some of the pictures of our training program. So in our training program, 3 modules happen in India. The 4th module, they go to UK and train in their real helicopter sorties. They go day and night flying. These are our team members who are going. They get a certification and exam there as well.